All right, so this lecture is going to cover not just diabetes medications, but also kind of go over a little more about the skills and calculations associated with administering medications for glucose. So some of these we've already kind of started on talking about in your clinical lab day, but this will be the official lecture and will be represented on your exam. So first, a little bit of background about diabetes and diabetic ketoacidosis. Hyperglycemia, this is an elevated glucose level. This is stimulated by the pancreas in most cases to release insulin and transports insulin into the cell. However, those with diabetes have an insulin deficiency or a cellular resistance, and this is also going to be the difference between type 1 and type 2. You'll get in later in your diabetes lectures. So then we're going to look at medications used to decrease that glucose level. So here's a video that you can watch on your own that talks about the differences of diabetes, type 1, type 2, and DKA, if this helps you understand how we're treating it. But essentially we have high blood sugar that we're treating and low blood sugar that we're treating. Now we need to know what the blood sugar is, so using a glucometer. Again, we've kind of established this in the lab, but here's another video as well that she goes through your steps. So you can watch on your own, but I'm going to quickly go through. You're going to wash your hands and sanitize, apply your gloves. Then you're going to have to scan the provider, which is you, scan the strips, and then the patient. So this we can't really simulate in the lab as we don't have an actual barcode scanner. But in the real world, in the hospital setting, you will have to scan the provider and they will have to have active credentials. The strip, which will correlate with the little the vial that you grab the strips from and ensure that it's not expired. And then scanning the patient's armband. Not their sticker, their actual band attached to their arm. Then once everything has been verified, then you can insert the strip into the glucometer. And then on the patient's hand, you're going to apply the alcohol pad to the site, cleaning it, and then allowing it to dry. Then you're going to grab your lancet and place it on your chosen location, usually on your fingertips. Once you have activated the lancet and you have a drop of blood, make sure that you wipe away that first drop. The first drop is slightly contaminated with the alcohol that may be there, still that residue. And it's very superficial capillary blood, which may not have a true level of glucose as their body system. So we want as true of a glucose level as possible. So we're going to then squeeze their finger, not milking, but just squeeze that area, which will push more blood out. And we're going to use that second drop onto the glucometer. Then you will apply your gauze to the site and make sure that the glucometer, while it's waiting for the result, is placed level. So just lay it flat on the counter or the bedside table. You don't want to have it inverted or running down either, but inverted will create that the blood can go inside of the meter and can damage the meter, and there's no way to clean that, and it clots inside of the meter. So making sure that it is level so that we don't damage our machines. Then apply a bandage to their finger if necessary. Once it's resulted, you can remove the strip from the glucometer and place the strip in the lancet in the sharps container, because this is contaminated with blood and the lancet is an actual sharp. And then you can throw away the rest of your items in the trash can. Sanitize your hands and then record the reading of the glucose level that should still be highlighted on the glucometer itself. Now also, since you scan this patient, you will have to dock the meter when you're finished in order for it to transfer into the patient's chart. So first are insulins we're going to talk about. These are going to provide glycemic control of diabetes mellitus to prevent complications, used when oral anti-diabetic medications, diet, and exercise are not controlling glucose levels, or if the client has severe renal or liver disease, painful neuropathy, or undergoing surgery diagnostic tests, we may resort to insulins in the short term. Severe stress situations can also increase the need for insulin. If they've never been on insulin before, they might be in the hospital as a result of the stressful situation. And also DKA, HHNS, and hyperkalemia can also have need the immediate and rapid treatment of insulin. So we have different types of insulins. We have rapid, short, intermediate, and long-acting. So you'll need to know the difference in these types of medications. So not just this is an insulin, but what type of insulin, how fast does it act on this client, because this is also going to change how often you monitor them and what signs and symptoms you're looking for at what period of time. So action times. Rapid-acting insulins are going to have a shorter onset, going to peak earlier, and will also die out faster. So just like the name entails, rapid acting. So in about 15 to 30 minutes, it should start acting and working on that blood sugar to bring it down. It will peak, so that is the highest point that this medication is in effect at the half-hour to 2.5-hour mark. So this is the time where we're going to make sure that we are still assessing our client, that they are not starting to decline or have any hypoglycemic symptoms. And then this medication can last 3 to 6 hours. And so we're still monitoring throughout the rest of the duration of the medication, and then hoping to not overlap another rapid acting if we are still seeing a rapid decline on their blood sugar. So this is usually, we'll have a sliding scale for this case. So if it's still on the decline or low enough, we won't need a rapid acting. Moving on to the short acting, it's a little bit longer, half-hour to an hour, peaks at 1 to 5 hours, and lasts 6 to 10 hours. Intermediate, 1 to 2 hours, peaks 6 to 14, and can last 16 to 24 hours. And then long acting is just over an hour, but it does not have a peak, is the difference here, and can last that 18 to 24 hours. So usually you'll see these long acting or intermediate acting medications, they might be getting them once a day or twice a day. So these are also referred to as basal insulins, because it's giving them a baseline background slow use of insulin in the background to continually regulate their glucose levels. And then they'll also get a rapid or short acting medication with meals or at bedtime for any spikes that they may have. So you may see both or 3 different kinds of insulins on the same client. So this is a chart I would recommend being very familiar with, potentially even memorizing, not just for the numbers, but also regarding what assessment time frame you're looking at. Now, when we are administering insulin, we're going to be looking at subcutaneous sites. So you have your A site here on the picture, which is going to be our preferred ones. And you'll see the orange is referring to what's in the bottom picture for the orange areas. When we do administer in the abdomen, we want to go in a clockwise rotation, and even inside of the square, you can do another rotation of sites. So, but making sure that we're staying away from the umbilicus, the umbilical belly button area. Remember, subcutaneous injections are into the abdominal fat tissue. when we do this, so make sure that you're pinching in order to stay in the fat and not into the muscle. Other options for clients are going to be in these B sites on the legs, the outer thigh, and then your C sites, which are on the outer part of their upper arm. It's not the deltoid muscle because that's a muscle, so don't refer to it as the deltoid. It is the upper arm on the outer side, the anterior lateral arm. Make sure that we're having a proper needle length and syringe type in order to make sure that we're getting it into this subcutaneous layer. So of course we're using an insulin syringe, but if we were for some reason to have an insulin syringe that does not have a needle already attached, make sure that you're using a correct size there as well. So make sure that we're not administering intradermal or intramuscular. Storage of insulin. Unopened vials of single type insulins can be stored in a refrigerator until the expiration date. What it means here by single type insulin is that it's not a combination. So sometimes we'll have an insulin that's like a 70-30. This 70 and 30 means 70% of this mixture is one type of insulin and 30% is another type of insulin. So this is a combination vial. So if they are just a single type of insulin in this vial, it can be stored in the refrigerator until the expiration date if it has not been opened. If it has already been premixed, such as that 70-30 version, it can be stored in the fridge up to 3 months. So after it has been mixed, it's only good for 3 months. Premixed syringes, if it's in a syringe, can only be stored for 1 to 2 weeks in the fridge, but it needs to be in a vertical position. So the needle needs to be up. I know this little icon is just a needle icon from PowerPoint, but don't let this icon confuse you. Make sure that you understand that the needle has to be up so that the medication is not being displaced into the needle area. It needs to stay in the syringe site area. And then prior to using it, we're going to gently rotate it in the syringe so that it mixes back into the correct consistency. Vials that are in use can be stored at room temperature as long as it's in an area away from the light and heat. But once they have been opened and started being used, they have to be discarded in 1 month. So multi-use vials, once they have been opened, have to be used within 1 month. Many times in the hospital, we'll still store these in the refrigerator, but it is still 1 month. Inhaled insulin is an option. These are dry powder cartridges that they'll inhale, and it can be available in 4, 8, or 12 units because this is how insulin is measured. So instead of milligrams and milliliters, the unit that we're using for insulin is units. Multiple cartridges may then need to be used in order to fill the dose if we're having to go through this dry powder way. So if they are ordered to have 20 units of inhaled insulin for whatever reason that they have burns all over their skin that we can't administer it subcutaneous, IV would be too rapid, we want some long-acting inhaled insulin of 20 units. We can do this, but you may then need, a 12-unit cartridge and a 8-unit cartridge. So make sure that you're still getting your full dose. IV insulin. So insulin can also be given through the IV route, but this is usually when we need a rapid glucose reduction. So we're concerned of HHNS or DKA, or it could be very soon, so we need to drop that blood sugar. These are clients that will be monitored in the inpatient facility, in the hospital, or the ER somehow. They need to be monitored after IV insulin has been given. Typically, this is regular insulin, and we can dilute it in normal saline as an IV push. Aspart Glucometer and Lispro are the only other insulins that can be given through the IV route, but typically it's just regular insulin for this rapid, immediate glucose reduction. After we have administered insulin, we'll need to flush with 50 milliliters of solution if it was given through a tubing, because it sticks to the lining of the tubing. So this is not talking about IV push. This is talking about insulin, like IV push to the direct hand. If we are giving insulin through the tube, instead of disconnecting, there's saline that's infusing for a bolus, and we administer it through the closest port. That insulin sticks to the tubing. So if you can give it closest to the patient as possible, disconnecting your tubing, the better. But if you do give it through the tubing, make sure that you're flushing violently, almost, through the tubing afterwards, or squeeze your bag in order to give it a little bit of a bolus, so that all of that insulin actually gets into the patient now and not over the next 30 minutes, if that makes sense. So flushing it rapidly off of the tubing so that the insulin will actually be administered to the patient and not a half dose and then the other half is stuck to the tubing, because insulin is sticky. So make sure that it is being flushed in. Premixed insulin, so this is like that version that I was talking about with 70-30. So this means that 70% of this insulin vial is NPH and the other 30% is regular. So this means this is a mixture of intermediate and short acting, because that's what regular is. Whereas 75-25 is going to be 75% Lispro and 25% a rapid acting Lispro. So there's the intermediate and the rapid mixed together. If they don't already come pre-mixed, we can mix them ourselves. So if they have an order for regular insulin and Lispro insulin, and so it's 3 units of Lispro, and then per the sliding scale we have to give now 2 units of regular. Instead of sticking them twice for insulin both times, we can actually mix them so that we're only sticking them one time. But you have to do it a certain way. So not really a mnemonic, but the saying is clear to cloudy. So you have to pull up the clear one first and then the cloudy, because you don't want the cloudy to contaminate your other vial. So first, with mixing insulins, you need to roll your insulins, make sure that they're at room temperature. The cloudy ones are usually your longer acting insulins. So your cloudy mixture, roll up to make sure that it is not separated, that it's mixed up still pretty well. But make sure that you're not shaking it also. Now we're going to pull up the air for the amount that we're using for the regular. Inject the air into the regular vial and then pull your regular back. Now you're going to pull your air for your cloudy amount, like NPH, your longer acting medication. Inject the air into that vial and then pull up that amount. So now you'll have your insulin glargine and your insulin NPH and your insulin regular in the same syringe together. So you'll see in the picture while this is not playing, so the red is the regular, and then your blue that is dotted is now your NPH. So you'll be administering a total of 30 units, but you had 5 of regular and 25 of NPH or whatever. So you still need to know your differences there, but you need to know also what you're supposed to be at your total so that you're drawing up the correct amount of your NPH. The only medications, insulin-wise, that we cannot mix are going to be glargine and detamere. So these ones, when they are ordered, they have to be administered by themselves. They have to be administered alone. They cannot be mixed or given through an IV route. So next we have calculations. We're going to calculate the amount of insulin our client is going to need based either on their sliding scale order or their weight. And this will also depend on, based on the medication, not just order physician preference. So usually your rapid acting will be based on a sliding scale, your rapid and short acting. So this is going to rely directly on what the client's blood glucose level is. So the example here would be your blood glucose minus 150 divided by 30. So if their blood sugar was taken within the last 15 to 30 minutes, that's like the max time frame from blood sugar to insulin, because you want to make sure that is very accurate and it is correct when you are trying to correct their blood sugar. So say their blood sugar was 210. So if their blood sugar was 210, you subtract 150 and you get 60. 60 divided by 30 is 2. So by that example of sliding scale with a blood sugar of 210, they would then receive 2 units of insulin. Novolog, Novolin, Humalog, whatever was ordered. They're short or rapid acting. This sliding scale insulin can be combined and added with other orders in order to limit injections to the client. So like in the example on the previous slide when we are mixing our insulins. Now per weight calculations, such as your long-acting insulins like detamere, it's going to be based on their weight in kilograms. So example here would be 0.4 units per kilo. So you would take their kilograms times 0.4, and that is how many units they're going to get. And usually this is once a day. Severe, hard to control diabetics might have it for twice a day, but usually the long-acting ones, because they act throughout the day, the basal insulin, background insulin, these are all the same or different terms for the same type of insulin here. The long-acting, so it's going to slowly administer, will slowly release and control that insulin throughout the entire day. So it could be, 30, 40, 70 units because it's based on their kilograms. But remember, these ones cannot be mixed. So if this one is being given in the evening time, and it's at the same time as their HS, so prior to sleep sliding scale, unfortunately before bedtime they will have to get 2 sticks if they have detamere. Now, giving insulin, we're giving it because they have a high glucose level. Now the concern then is if it drops it too much. So hypoglycemia is when our glucose level is below 70. This could be a result from too much insulin that was administered, or we corrected them correctly, but they didn't eat enough food at that time to counteract these complications. They've had any vomiting or diarrhea, alcohol, exercise, and childbirth. Can overuse the effects of the insulin and cause the glucose to drop more rapidly. So symptoms that we're looking for on our assessment at those peak times throughout the duration are going to be for tachycardia, palpitations, diaphoresis, shakiness, headache, tremors, weakness, lethargic, disorientation, and other things, confusion, not acting right, any change in level of consciousness from their baseline, things like that. So if they are conscious, we can treat this hypoglycemia with 15 grams of carbohydrates. Yes, you need to know how to come up with 15 grams of carbohydrates. Here are different options. You can give them 4 ounces of orange juice. That's 15 grams. Or, this is in addition to, or 2 ounces of grape juice, or 8 ounces of milk, or glucose tablets, which will need to be, of course, 15 grams total. Those are all through the oral route. They have to be conscious at this point. But if they are unconscious, then we do have to resort to a parenteral injection of glucagon. IV is the preferred route here. That's why it is bolded. However, if for some reason they don't have an IV, it's not working, or usually this is like a family member that's come to visit them and they're stressed. So they took their insulin, they're stressed, they didn't get to eat at the right time because they're coming to visit their family member, and now they have bottomed out and passed out. And we'll have to give them glucagon IM. If clients are taking insulin, we like to educate them about how they should be wearing a medical alert bracelet and have a snack with glucose handy on them at all times. Just in case they were to have one of these episodes or even lose consciousness, people responding to them will then be aware that, oh, this could be due to their glucose level. Another concern that can happen with insulin is related to potassium. So it could cause their potassium levels to decrease, so hypokalemia. So looking for things such as muscle cramping and cardiac dysrhythmias on our assessment. And then lipohypertrophy, which is an infection of the fatty tissue. So this is especially why that we rotate the sites and making sure that we're at least 1 inch between the previous site and the new site that we're giving to prevent this complication. Oral hypoglycemics. These are pills that are going to decrease their glucose level as well, but not insulins. So examples are going to be like listed here: clopropamide, glipizide, metformin, and sitagliptin. These are going to promote or increase the insulin from the pancreas, increase the glucose uptake, reduce the production of glucose, increase the response to insulin, slow carbohydrates absorption, or excrete glucose through the urine. Either one of these pathways is going to decrease their glucose level, which is our goal. But again, here our concern are going to be hypoglycemia, but we also have weight gain as a concern with our oral glycemics, especially in the cases of glipizide. We can also have GI effects, weight loss, B12 and folic acid deficiency, and lactic acidosis can occur from those taking metformin. And this is a very common one on the market. So being aware of these complications here. And then with sitagliptin, we can also have pancreatitis, especially in the cases that they have been on this medication for quite some time. So we need to be considerate of those that are have renal, liver, or heart failure, and educate them to take this on an empty stomach, except for metformin. Metformin should be taken with meals. And so remember this in that it causes GI effects, so nausea and vomiting things already. So in those cases, just like with other medications that do cause GI effects, if we take it with food, it can decrease those effects. But remember, all of the other ones we are going to need to take on an empty stomach. We are taking this for hyperglycemia. Remember, so just like with insulin, it's going to drop their blood glucose. So we're going to take this on an empty stomach in order to increase the absorption so that all of it is being taken in by the client. Like when we give IV insulin through the tubing, making sure it gets all the way into them. We do not use oral glycemics, hypoglycemics, to treat DKA. If a client is in diabetic ketoacidosis, so they have those ketones, their labs are showing acidosis, they need to be on something more controllable and rapid than oral hypoglycemics. They're not managed. Oral hypoglycemics are for those that are well managed at that time. Then also we need to educate about exercise and diet changes to help control their diabetes. Okay, so flipping to the other end of glucose levels, if a glucose level is low, we're going to use a hyperglycemic agent. So the agent is going to cause hyperglycemia is our goal. So glucagon is our example. So these are used in the emergency management of hypoglycemic reactions when an oral or IV glucose are not an option. But when we do this, it can cause GI distress, severe nausea, and vomiting can happen. I have witnessed this almost every time that I have given IV glucagon and they have woken up, that it causes severe nausea, hypersalivation, and they vomit. Not every time, but most times they will vomit. If not, they get the severe nausea. It's a sudden increase in their glucose levels. So sugar high, or like when kids eat too much sugar and their tummy hurts and they just don't feel right. And this is what they're having in 0.2 seconds. So turning them on their side, just in case they do start to vomit and they haven't fully regained their abilities to prevent them from aspirating. Now, we're going to administer this IV, IM, or sub-Q until they gain consciousness. So then once they are conscious, they don't need an IV or IM glucagon. We can now switch to their oral glucose supplements until their glucose has reached above 70. And now, once they hit 70, we are no longer considered hypoglycemic at this point. So remember your oral supplements of glucose for your 15 grams on the previous few slides. So this completes the lecture regarding diabetes medications for hyperglycemics and hypoglycemics, your skills for your glucometer, and the calculations for by weight and by sliding scale. This came from your textbook from pages 309 to 315. Let me know if you have any questions. There will be an open discussion board for any muddy points. Thank you.